Hi, everyone. My name is Pete Carey, and what I'll be pitching today is the disparities in access to care for Illinois Medicaid patients. The client I'll be pitching to is Third Horizon Strategies. And on the right side of the screen here, you can see I included a snippet of their website that gets into more of the specifics of what they focus on, including Medicaid. The problem I'm posing is what can Illinois do at the state level to ensure equitable access to care for their Medicaid patient cohort? For some background, related to reimbursement, it's a well-known fact in the healthcare industry that providers receive wildly different rates for providing the same services depending on what the insurance is. For example, Illinois Medicaid pays about 60% of Medicare rates for all services and only 44% of Medicare rates for primary care. You can see on the right side here, I've included the top 10 most populous states and those primary care rates relative to Medicare. And Illinois comes in ninth out of 10th at that 44% rate, relative to North Carolina, which has a 78% rate relative to Medicare. For additional context, private insurance pays about 200% of Medicare rates. All of this to say, all the incentives for our healthcare providers are pointing towards catering to those with private insurance rather than those with Medicaid. Additionally, physicians are 25% less likely to accept new patients that are insured by Medicaid when compared to Medicare, and 30% less likely when compared to private insurance. And that plays out in the primary care outcomes for Medicaid patients. You can see on the right side here that for those same 10 states, the outcomes that Medicaid at a federal level keeps track of, Illinois comes in dead last, with 13 out of their 17 reported outcomes being below average. For the policy landscape, Medicaid is approximately a quarter of Illinois' yearly budget, and spending has nearly doubled in the past decade, though spending per enrollee has declined over that period. Illinois has enjoyed budget surpluses for the past 2 fiscal years, and a state widely known for budget deficits that doesn't leave much political will to greatly increase expenditures. Illinois did pass a law recently that expanded access to care for undocumented immigrants, which drew the ire of conservative lawmakers. All this to say, the conversation politically has been focused on expanding coverage and not taking that next step to say, how do our Medicaid patients actually access that coverage once they have it? And socially, and most importantly, I believe, approximately a quarter of the children in our country, even with parents who have employer-sponsored insurance, still receive their health care through Medicaid, or more specifically, CHIP. This is likely due to the burdensome cost-sharing requirements for employer-sponsored insurance. So much of our nation's youth is receiving healthcare through Medicaid. For the status quo, so what is on the books? Illinois does have some network adequacy requirements, but it is not nearly enough. One that I want to call out specifically is the time and distance requirement. It states that all enrollees have access to at least 2 primary care providers within 30 miles or a 30-minute drive. Medicaid patients are often the most poor and sick in our communities and do not have access to a vehicle for the most part. So this is a non-starter in terms of requirements for making access to care equitable. In addition, Illinois decided not to extend the ACA's primary care payment parity policy that increased primary care reimbursement rates to match Medicare for 2013 and 2014. Congress allowed this law to expire in 2014, and Illinois as a state decided not to extend those rates, which leaves us at that 44% relative to Medicare that we have today. For market failures, a combination of a lack of appreciation of positive externalities of primary care and inconsistent time preferences on the part of providers have kept them from being able to engage fully in creating equitable access to care for Medicaid patients. From the government perspective, programs like the DISH program, which subsidize acute care in safety net hospitals, have made it financially viable to treat Medicaid patients in an acute setting, but there is not a corresponding program on the primary care side. And in addition, the government has failed in largely allowing the market to decide whether they accept Medicaid patients because markets operate on different timescales than governments. Providers, though they are often nonprofit, do need to turn a margin to keep their doors open, whereas the government is largely interested in the long-term health of its citizens. And investment in primary care is largely a long-term benefit, which keeps these providers from being able to accept those low rates today and close due to financial constraints before they see those benefits in the future. And that was my pitch. I hope you came away from this agreeing with me that Medicaid equity and access is a worthwhile issue. And I hope you have a great rest of your day.